to the deep dive. Today we're taking a look at a crisis that is really fundamentally reshaping the U.S. healthcare workforce. We're talking about physician and clinician burnout and this huge structural great exit that's pushing so many skilled professionals into non-clinical jobs.
It really is a seismic event, and our mission today is to get past the headlines about, emotional fatigue. We're going deep into the hard data,
Right.
the measurable business impact of this whole exodus, the financial ROI for systems that actually try to fix it, and the very real career paths that are now pulling nurses and doctors away from the bedside. This is a story about a broken system, not broken people.
Okay, let's unpack that. And I think we should start with just the sheer scale of the shift. The sources we looked at have data that is, well, it's just defining this entire era. A recent survey found the majority of physicians, was it 62%?
62%, an astonishing number.
Made some kind of career change between 2022 and 2024.
And you really have to let that sink in. 6 out of every 10 doctors. They actively chose to change their job, their scope, or even their field entirely in just 2 years.
Yeah, that's not just a normal retirement cycle. That's something else.
Exactly. This is a massive, aggressive realignment across the industry. And it's happening because clinical work, as it's currently set up, is becoming unsustainable for way too many people.
So how do we quantify that? I mean, beyond that top-line number, what does the data tell us about what the workforce is feeling right now?
Well, we can measure it in a couple of ways. There are the formal burnout metrics, and then there's this quieter trend of, quiet quitting.
Okay.
So looking at hospital medicine, for example, about 45% of hospitalists meet the strict criteria for clinical burnout. And if you broaden that out to all practicing physicians, it's still incredibly high. About 43.2% report major symptoms.
Wow. So almost half the people responsible for frontline care are just running on empty. That feels like a staggering liability for any organization.
It is. And honestly, the picture gets even darker when you look at quiet quitting. In one big survey of healthcare professionals, nearly 6 in 10, 57.9% were identified as quiet quitters.
So they're just disengaged, doing the bare minimum.
The absolute bare minimum required to keep their job. Nothing more.
And if we break that down by role, I remember seeing one demographic that's pulling back the hardest. And it's a group you really don't want pulling back.
No, you don't. It's the nursing staff. A full 67.4% of nurses, that's more than 2/3, were classified as quiet quitters in that study.
Wait, 2/3? Compared to what for other roles?
Compared to 40.3% for other healthcare workers. So nurses are disproportionately affected.
So the very people who are most critical for bedside care, for patient safety, they're mentally checking out. It sounds like the engine room of the hospital is just running on fumes.
That's the perfect way to put it. And when you ask why, the conversation has completely shifted. It's no longer about, the inherent stress of the job.
Right.
The sources all point to specific structural problems that the system itself has created.
And what's at the top of that list?
The number one catalyst consistently is administrative burden. It's just clerical work. U.S. clinicians are drowning in it compared to their peers in other high-income countries.
I saw a stat that was just mind-blowing.
The 26.7-hour stat.
Yes. That to do all the recommended care and all the required admin, a doctor would need almost 27 hours in a single day. That 2.7-hour deficit has to come from somewhere.
It does, and we all know where it often comes from.
The EHR, the electronic health record. The sources we looked at frame it as a constant tax on every single patient interaction.
It's a perfect description because it forces this impossible trade-off. The EHR demands slow, meticulous documentation, but that directly competes with having a quality conversation with the patient.
So you either rush the patient or
you take the work home. And that's where we get the term pajama time. It's those hours you spend on the computer after your shift, documenting. Unpaid and unrecognized.
And that ties right into this concept of moral injury, doesn't it?
Absolutely. Moral injury is what happens when the system forces you to violate your own professional ethics. You took an oath to provide good care.
And the system makes it impossible.
Right. High patient loads, 93% of one group cited that, and the constant pressure to hit performance metrics. It creates a workload where you're compromising patient safety. The distress isn't from treating sick people, it's from the operational demands of the system you're stuck in.
That human cost is just enormous. Are there specific groups, specific cohorts that are at the highest risk right now? Where should leadership be focusing?
Yeah, the data points to a few critically vulnerable groups. First, hospitalists who are employed by those big national management companies, their burnout rates are the highest at 66.7%.
So a focus on standardized metrics over local control seems to be a key factor there.
It seems to be. Second, there's what we're calling the 4-year wall for early career hospitalists. In their first 2 years, burnout is around 42.8%.
Okay, still high, but
But then, in that 3 to 4 year window, it skyrockets to 62.2%. That's the point where they're no longer new, the pressure is on, and they just get overwhelmed.
and that leads right to the third group, which is the mid-career staff, the 35 to 44-year-olds.
Correct. This group is the most likely to quietly quit. They are absolutely crucial for an institution. They're the ones who should be mentoring the new people, stepping into leadership. When they mentally check out, the whole pipeline just breaks.
So we've laid out the human cost. Let's switch to the dollars and cents. Because resignation isn't just a morale problem, it's a catastrophic financial problem.
It's a massive financial event. Unaddressed burnout costs the U.S. healthcare system somewhere around $4.6 billion annually.
$4.6 billion.
Yep. And that's mostly driven by turnover, recruitment, and just lost clinical hours.
And the cost to replace just one person is. It's a number that people need to hear and really understand.
It is. Replacing a single physician can cost anywhere from $500,000 to well over $1 million, depending on the specialty.
And where does all that money go?
You're talking about recruitment fees to headhunters, huge sign-on bonuses, relocation packages, all the lost billing while the position is empty, and then months of onboarding for the new person. It takes years to get that money back.
And it doesn't just hit the hospital's budget. The impact trickles down to patients, creating these hidden costs.
Oh, absolutely. There's a documented cost to losing your doctor. For Medicare patients, they end up spending an extra $189 in the year after their primary provider leaves. It's just from the inefficiency of starting over, fragmented records, duplicate tests. It costs everyone.
You also found something really interesting for managers listening right now. A data point that proves engagement is literally a financial buffer against people leaving.
Yes, this is one of the most practical takeaways. We call it the buffer effect. Look at the numbers. A disengaged employee, they'd leave for about a 22% raise.
Okay.
But an engaged, happy employee requires a much bigger incentive to leave, about a 31% raise, that 9-point gap. That's the financial value of a good culture.
So you're actually saving money by investing in keeping people happy because you don't have to compete as hard on salary just to keep them from walking out the door.
Exactly. It literally costs you more to retain an unhappy person than a happy one. It makes retention a fiscal priority, not just a nice to have.
So let's talk about the ROI of actually trying to fix this. Are wellness programs just feel-good expenses, or do they actually pay for themselves?
They are demonstrably fiscally responsible. So, in general, an employer-sponsored behavioral health program has a documented 1.9 to 1 return. For every $100 you invest, you get about $190 back in reduced medical claims.
And we have a really specific, powerful case study on this too, right?
We do, from Dignity Health. Their internal medicine department made a targeted investment of $120,000 a year into wellness. This included hiring an organizational psychologist, starting a peer mentorship program, things like that.
A relatively small investment in the grand scheme of things.
Very small. And that investment delivered a 210% return on investment. It saved the department $370,000 a year, almost entirely by reducing physician turnover. It's a clear, fast payback.
The ROI is there, but a lot of clinicians still decide that the best strategy for them as an individual is just to leave the bedside. What are they looking for when they make that choice?
The priorities are really clear. It all centers on sustainability. The number one motivator for a career change for 51% of physicians is just a better work-life balance.
That's followed by a more flexible schedule.
Right, at 34%, and then a better workplace culture at 29%. They're voting with their feet for a life that actually allows them to have a life.
And the data shows a pretty significant gender split in those motivations.
It really does. And it highlights why you can't just have a one-size-fits-all retention plan. Women are much more motivated by work-life balance at 58%, and flexibility at 41%.
Whereas men
were almost twice as likely to change jobs specifically for more money. That was at 36%. If you're not paying attention to those nuances, your incentives are going to miss the mark for half your workforce.
One of the biggest pivots we're seeing is the move to temporary work, or locum tenens.
Locum tenens, yeah. It means holding the place. It's essentially temporary traveling contract work, and it's become this huge escape valve. It gives you autonomy, often high pay, but without all the organizational baggage.
And the numbers there have just exploded.
They really have. 44% of physicians who changed jobs went to work locum tenens. That's up from just 28% 2 years ago. And here's the kicker. Independent contractors, including locums, report the highest career satisfaction in the entire industry, 75%.
So the ultimate escape is the pivot to a full-time, non-clinical role. This used to be a pretty niche path, but it seems like the market has just absorbed this talent incredibly quickly.
Oh, the growth is it's explosive. The non-clinical job market for healthcare professionals grew by almost 59% between Q1 and Q3 of 2025 alone. And it shows that other industries are finally realizing that having that clinical expertise gives you this unique, indispensable credibility for roles far away from the bedside.
Like a medical director at a pharma company or a clinical informatics manager, a consultant.
Exactly. Medical writing, too. And you can see the appeal. You get predictable hours, often remote work, and crucially, you get a chance to influence patient care on a systemic level. They're going from treating one patient at a time to trying to treat the system itself.
But for those who can't or don't leave, we see that passive withdrawal, the quiet quitting behaviors that sort of erode the hospital from the inside out.
And it shows up as strategic boundary setting. We see 43% of doctors admitting they cut documentation down to the bare minimum.
Just enough to get paid, basically.
Pretty much. 37% have actively cut back their patient-facing hours. 43% have turned down leadership roles they were offered, and 37% have skipped optional professional development.
And those are all rational decisions for an individual who was trying to protect themselves.
Yeah.
But for the organization, it's a disaster. You're losing mentors, leaders, and all that institutional knowledge.
Exactly. And that brings us to the institutional strategy, because the consensus has finally, thankfully, shifted away from just telling people to be more resilient.
Right?
The thinking now is that resilience training is it's the wrong prescription for an organizational disease. The focus has to be on organizational interventions. Experts are calling it the 4 T's: teamwork, time, transitions, and technology.
So let's start with T for technology, since that seems to address the biggest pain point, the admin burden. Ambient intelligence seems like a huge step forward.
Ambient AI is an absolute game changer. These are AI tools that listen to the patient conversation and then automatically structure the notes right into the EHR.
So it eliminates that pajama time.
It almost completely eliminates it. The studies are showing a 40% improvement in provider wellness and up to a 75% reduction in after-hours documentation.
And there's a dual benefit there, right? The clinician gets their life back, but they can also just focus on the patient instead of a screen.
And that improves the patient experience by about 13%. It is a clear, measurable win-win.
Another key technology is predictive scheduling.
Yes, using machine learning to forecast patient surges, especially in places like the ER. The tech is getting up to 91% accuracy for the next day. This lets managers staff up before things get unsafe, not after everyone is already drowning.
Okay, so moving past tech, what about the operational redesigns? The other T's, like transitions and teamwork.
The CIC model is a really important one. It stands for continuity. And the whole idea is to prioritize keeping a single doctor on a patient's case for their entire hospital stay.
Instead of a new doctor signing off every 24 hours.
Exactly. And when they did this, they saw a 7.5% reduction in the length of stay, and they cut the average hospital charge by $617 per patient. Better continuity leads to faster, more efficient decisions. It saves time and it saves money.
Which just shows how workload and safety are so deeply connected.
They're two sides of the same coin, and that leads directly to workload caps. The data shows that high workloads drag out the length of stay. Establishing firm, safe caps isn't just about morale, it is a patient safety and efficiency imperative.
And what about retaining older, more experienced clinicians?
A huge piece of the puzzle. Physicians over 55 make up 42% of the workforce. So smart organizations are creating flexible pathways for them, tapered clinical schedules, shifting them into mentorship roles, administrative work, anything to keep their expertise in the building.
So if we just try to synthesize all of this, the bottom line seems crystal clear.
It is. For the individual, leaving or pivoting to locums or a non-clinical job is a completely rational response to a dysfunctional system. But for the hospital, that resignation is just too expensive. It costs up to $1 million to lose one doctor.
So this conflict isn't really a crisis of individual stamina anymore. It's not about a lack of grit. It's fundamentally a crisis of systemic design and architecture. And redesign is the only sustainable way forward.
Which brings us to a final thought for you, the listener. The future of healthcare systems will be defined by whether leaders have the courage to stop demanding individual resilience and start providing tactical, systematic support. We've shown it's a business imperative with a multi-million-dollar ROI, not just a moral one. So what systemic failure are you protecting yourself from in your own workplace? What boundaries have you had to build? And what would it take for your organization to finally acknowledge its own architectural flaws?